A century ago, tuberculosis was a dominant cause of death. Hundreds of thousands of people filled crowded sanitariums, stripping entire communities of a generation. But then came the introduction of the BCG vaccine and widespread chemotherapy. By the 1960s, case numbers had plummeted to a fraction of their historical peak. The public and medical consensus shifted. TB was reclassified alongside plagues and sweating sickness, a closed chapter of Victorian medical history. That overwhelming medical triumph created a dangerous blind spot. Assuming the war was permanently won, society looked away, giving the pathogen the quiet space it needed to adapt. This infographic shows the estimated incidence of TB across Western Europe. While neighboring nations like France and Germany hover around 8 cases per 100,000 people, the UK sits noticeably higher, with a rate of 10. This map breaks down English data. Infection is highly concentrated into a dense red cluster over Greater London. Zooming into the capital, the crisis peaks in localized boroughs like Brent and Newham, where rates spike past 50 cases per 100,000. How does a 19th century disease manage to survive and multiply inside one of the most highly developed modern cities on Earth? Pathogens do not respect historical milestones. Keeping a modern metropolis safe requires an invisible, actively maintained system of defense that constantly monitors the population. That invisible shield is called health protection. It is a broad network of public health protocols designed to intercept infectious threats before they can spread. When an outbreak occurs, authorities execute a specific 3-step tactical playbook known as communicable disease control. Step 1 is hazard identification. When a physician diagnoses a serious threat like TB, they must notify public health to get the case on the radar. Next comes risk assessment, analyzing data to find the vulnerable. Finally, intervention, deploying targeted plans to break transmission. Starting the risk assessment on a global scale reveals that modern TB has formed a devastating biological alliance with HIV. This world map estimates HIV prevalence in new TB cases. In the dark blue regions, 50% or more of TB patients are also living with HIV, drastically complicating the hazard as the bacteria attacks already compromised immune systems. Bringing the risk assessment back to the UK, we can analyze regional records, like those from Northern Ireland, to find out exactly which demographic groups the disease is hitting hardest. This chart graphs TB case rates over a 14-year period. The data shows a stark split. The infection rates for non-UK-born individuals, tracked by the top line, are drastically higher than the rates for the UK-born population along the bottom. Public health tracking shows that these demographic disparities often overlap with specific social risk factors. In the hardest-hit urban areas, the bacteria finds its strongest foothold among underserved populations facing overcrowding and economic deprivation. The statistical consequences of these inequalities are severe. Patients burdened with these social risk factors are twice as likely to be highly infectious and twice as likely to die from the illness. TB functions as an opportunistic pathogen that specifically hunts the socially and economically vulnerable. Once the risk is assessed, the intervention phase should be straightforward. Tuberculosis is an entirely curable disease when treated with a strict 6-month course of antibiotics. But the defense system is breaking down right at the finish line. The most vulnerable patients are experiencing severe delays in entering the treatment pipeline. Currently, over 28% of all TB patients wait more than 4 full months from the onset of their first symptom until they finally start their medication. Biologically, this gap is disastrous. It gives the bacteria time to mutate and develop resistance to standard drugs, creating a much harder strain to kill. Societally, infected individuals spend those 4 months unknowingly transmitting the disease throughout their dense urban communities, driving up massive financial and operational strain on the National Health Service. As long as global populations continue to move and stark urban inequalities persist, health protection cannot be treated as a solved problem. It must remain a relentless, active fight, or the diseases of the past will quietly dictate our future.